And the coagulation profile is very important, the INR, the APTT and the platelets. Now the basic management. So you have to assess the airway intubation for the high risk patient, you have to assess the breathing nature, you have to administer oxygen, you have to maintain a tidal volume of 6 ml per kg, you have to assess the circulation, you have to give the fluid, you have to maintain the mean arterial pressure more than 65, you have to maintain the CVP, you have to maintain the hematocrit, and you have to start the drug therapy with broad spectrum antibiotic, and you have to control the source of infection, like if there is any abscess or empyema or cholecystitis or cholangitis or urinary tract infection, or there is necrotizing fasciitis or gas gangrene, like that. Now, antimicrobial treatment in sepsis. So timely administration of bactericidal, adequate initial coverage for all likely pathogen. You have to assess the risk of MDR and consider the result of rapid diagnostic test. Escalation and de-escalation, you know, it's a very much used term nowadays. That is the escalation and de-escalation of your antibiotic regimen according to the assessment of the microbiological result and short duration for most patient, adequate dosing and adequate route, and individualized further doses like depending on the PD and PK, altered fluid balance, third space, altered protein binding, or there is a impaired renal function or impaired liver functions. So know your patient. There is a quick SOFA that I always tell to our juniors that at least learn this thing. This is very helpful thing. You know the SOFA score is it's a ICCU parameter, and you need a ICU setup to score it, the SOFA score. But nowadays we are having the smartphone with you, and if you go for the quick SOFA, then it is very easy to identify the patient outside the ICU in your emergency or in your ward with a suspected infection and the high risk of hospital mortality. Here you can prognosticate the patient and you inform the patient party accordingly. So what you have to do? You have to check the mental status, whether the patient is alert, oriented or not, whether the patient is having respiratory rate more than 22, whether the patient is having SBP less than 100. So you can do for all patients of the more than 18 years of age in your emergency, ward and recovery room. And you have the apps in your smartphone, you go for it, and it has been estimated that quick SOFA more than 2 is bad for the patient. Now antibiotic timing, so I will come to that later on. First we go to the duration of the antimicrobial therapy. So prolonged duration of antibacterial therapy is associated with increased resistance. So that is very important. So nowadays when we admit the patient in our ward, we used to give the antibiotic for 7 days, 10 days. So this unnecessary prolonged duration of antimicrobial therapy will lead to increased resistance. You know that the clinicians are nowadays just fighting to have a new antibiotics because almost all our important antibiotics are getting resistance to the common pathogen. So it gives rise to your resistance. Another thing is drug associated adverse effect and obviously higher cost. Now it has been estimated that disregarding some special situation like your infective endocarditis, gram-negative meningitis, osteomyelitis, the prolonged antimicrobial therapy is not basically important. And reducing the duration of antibiotic treatment is the most effective strategy to reduce the antibiotic resistance by reducing the pressure on the endogenous flora and selection of resistant strain. Now the important thing, we frequently do this, that what are the biomarkers to guide the antimicrobial therapy in the sepsis. So this is very important nowadays. We are having two important biomarkers with us. One is the CRP, another is the procalcitonin. So procalcitonin is only for the bacterial infection. You know that it is very much specific for the bacterial infection, and it is when procalcitonin is low, it is basically you can say that the bacterial infection is ruled out. Now the half-life of PCT is almost 24 hours. So though PCT is a costly test, you cannot recommend it every 48 hours or 72 hours. But in some cases when you are having a problem, you can do PCT serially to assess your response. So several studies have evaluated the contribution of algorithm guided PCT plasma level to reduce the duration of the antibiotic treatment. So that is important. On the time of admission, you have a sky high PCT, and with your antibiotic treatment the patient is having gradually lowered down the PCT. So you are a little bit relieved that your antibiotic is working. Now it is very important. So please do the de-escalations. So different tools have been developed in order to promote de-escalation. You know that it's a much used term nowadays that de-escalation is very much necessary. In an attempt to eliminate those concerns that hindered the clinician from implementing best available scientific evidence, there are educational programs to promote the de-escalation among professionals, novel microorganism identification technique, and the use of biomarker to guide the decision. Now what happens? Actually, novel microorganism identification technique are coming each and every day. Our microbiologist friends are doing, and I think if any one of them, we have a good microbiologist with us, Dr. Kumar. Ironically, he is outside now. But in microbiology, you have heard that there is a lot many of your rapid identification technique is coming, and what that will help us to reduce our antibiotic spectrum. So that is the de-escalation in that is very much necessary. Because nowadays if you do the urine culture, it will take at least 48 hours, and if you do the blood culture provisionally in SONOSCAN, we have the blood culture provisional report within 3 working days, but the final report comes a little bit later. So if we gradually, with the advancement of science, we have the more and more easy or short identification technique, then we can just narrow down our antibiotics accordingly. So several initiatives promoting the streamline of antibacterial therapy have been implemented to increase the antibiotic de-escalations. Now dose optimization that we always do according to the PK and PD in if the patient is suffering from CKD or if the patient is suffering from hepatic failure, we have to adjust the dose, or if the patient is suffering some abnormal volume distribution like we always find in dengue patient, the capillary syndrome, the hypervoluminia, all that. So you have to adjust the dose accordingly. Now the dose optimization. An individualist approach for antibiotic dosing is therefore required for patient with sepsis, and therapeutic drug monitoring contributes to the valuable information to that task. So nowadays it is very important. Today's time you just can't afford giving antibiotics for prolonged period to your patient. You need to do the therapeutic drug monitoring. So therapeutic drug monitoring has been well accepted all over the world for the aminoglycosides and the glycopeptides like vancomycin. So the recent evidence nowadays also suggests that you should do therapeutic drug monitoring as a useful strategy in the beta-lactam cases. Now it is a gross slide which I have just built up from my knowledge. It varies from institution to institution. In our Indo, we treat the immunocompetent patient with piperacillin tazobactam, imipenem silastine, meropenem, colistin and minocycline. We have used very little amount of minocycline, perhaps in my last 8 hours 1 or 2. And if there is allergy to beta-lactam agents, we use Cipro, Levo plus clindamycin, and vancomycin we add necessarily to each and above agent. And if there is a neutropenic patient, we give the imipenem silastine or meropenem or cefepime, piperacillin tazobactam plus tobramycin, vancomycin if indicated we give, and empirical antifungal therapy is very much needed if the patient is hypotensive and receiving broad spectrum antibiotics. Now other special situation, you all know the splenectomy patient, the cefotaxime, ceftriaxone with vancomycin, and IV drug user, the vancomycin. In AIDS, you have to use the cefepime, the plus tobramycin, cipro, levo plus vancomycin plus tobramycin. Now you have to control the source. That is very important. That you have to focus the source also. Like evaluation of a focused infection is very important. Along with that, if there is any abscess drainage is necessary, like in liver abscess or any pyogenic abscess in any site of the body, you have to to drain the abscess, and tissue debridement also necessary. And if there is a management of hypotension, you have to give the fluid challenge over 30 minutes. We always give 500 to 1000 ml of crystalloids or 300 to 500 ml of colloid and repeat on the basis of response. Now the very important thing, that is a surviving sepsis campaign, the international guideline on the management of sepsis and septic shock. So I will just read out the recommendation, because it is my endeavor to have a knowledge for we the physicians to treat the septic patients according to the guideline. Now for hospitals and health system, we recommend using a performance improvement program for sepsis, including sepsis screening for acutely ill, high-risk patient and standard operating procedure for the treatment. Now for adults with suspected sepsis and septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobial as compared to clinical evaluation alone. Now for adults with possible septic shock or high likelihood of sepsis, we recommend that administering antimicrobial is immediate within 1 hour of recognition. For adults with possible sepsis without shock, we recommend a rapid assessment of likelihood of infectious versus non-infectious causes of acute illness. For adults with possible sepsis without shock, we suggest a time-limited course of rapid investigations, and if there is a definite concern for infection, then we will administer the antibiotic within 3 hours of the time. Now antibiotic timing, what I have skipped, that is, in one arm shock is present, in the another one shock is absent. So sepsis is definite or probable. In both the cases, you have to administer the antimicrobial immediately, ideally within 1 hour of recognition. That is, the patient being admitted in your institution, you have to give the antibiotics. Now where the sepsis is possible, so if there is shock is present, then you have to administer the antibiotic immediately. And if the shock is absent, then you go for the rapid assessment of infectious versus non-infectious causes of acute illness, and you can just administer the antimicrobials within 3 hours if concern for infection persists. Now for adult with sepsis and septic shock, high risk of MDR, we are facing nowadays, there is high risk of MDR. We suggest using 2 antimicrobial with gram-negative coverage for empiric treatment over 1 gram-negative agent. And for adults with sepsis or septic shock with a very low risk of MDR organism, we suggest against using 2 gram-negative agent of empiric treatment as compared to 1 gram-negative agent. For adults with sepsis or septic shock, we suggest against using